sitting on the floor. Right? Like, no, I'm that in a corner here. Okay. So you had an endoscopic excision of your carcinoid. Laparoscopic or endoscopic?
Oh, right, yes.
Did they do it with a colonoscopy?
Eventually, it was an endoscopy. They found the polyp, and then it was it was really confusing. So, because it wasn't all done here. It was after seeing a number of doctors.
Good, well, you've researched everything. So the good news is that, and I know you've been here for a while, but I'm going to take notes of everything important so you have it for home. But the good news is that the cure rate of breast cancer has improved significantly over the past few decades, and we know the best way to treat it is by using multiple modalities to treat your cancer. So you've had surgery, and you've had appropriate bilateral surgery, which makes sense for risk-reducing surgery because of the mutation. And after that, the next thing we recommend is what we call adjuvant chemotherapy. Adjuvant means chemotherapy after surgery.
Okay.
Neoadjuvant means chemotherapy before surgery. And that's sort of the next step. When I think of treatment of breast cancer, I think of it two ways. I think about the local treatment. How are we going to treat the cancer, the tumor that was found in your breast? There's two local treatments. One is surgery, and you have had appropriate surgery and don't need additional surgery. And the second is radiation therapy. And they probably told you this, but I'll just reiterate it. A lumpectomy, cutting out the tumor and the surrounding tissues, plus radiation therapy equals a mastectomy or removal of your breast in terms of overall survival. And if you do a mastectomy, in your case, you do not need radiation therapy. Right? That should have been told to you at some point. And it also decreases not only it decreases an in-breast recurrence because you don't have any more breast tissue. Dr. Altimer took out as much breast tissue as he possibly could. Okay, it's impossible to take every little bit out, but he got 99% of it out. So that significantly reduces your risk of having another breast cancer. So local treatment's done. So now you come to breast medical oncologist for systemic treatment. Systemic treatment is how we treat the rest of your body. The goals of it are to decrease risk of recurrence. Because you had this tumor that was diagnosed in July, but first felt in January. And sometime between January and your recent surgery, there's a chance that cells could have escaped the breast. When you have a cancer and it starts here and becomes invasive and goes through the membrane, any cancer that becomes invasive has the possibility to travel to other parts of your body. The goal of systemic treatment is to kill those cells, and by killing those cells, it improves your survival. So we know if 100 women just get surgery, or 100 women get surgery followed by chemo, more women will be alive with your type of cancer if they get the chemo. What we don't know is which patients are cured because of the chemo and which would have been just cured with the surgery. Because just doing surgery will cure a number of patients. But we know chemo on top of it will cure even more. And more people will be alive because they got the chemo. But for any given patient, we can't distinguish what cured them. But we don't really care because if a combination cures you, we're happy. Okay? So the goal of systemic treatment is to kill microscopic cells that may have escaped and kill them before they have a chance to set up shop in your liver, your lungs, your bone, or anyplace else. Right now you have a stage 2 breast cancer, 2A, 2.1 centimeter tumor, and the goal is to be aggressive now to try to decrease the chance of it coming back. If it comes back and it's found someplace like your bone, your liver, your lung, your lymph nodes, your brain, it goes from stage 2 to stage 4. Stage 2 is potentially curable. Stage 4 is not. It's treatable but not curable. And our goal is to try to prevent it from becoming stage 4. There's no guarantees. Anytime you have an invasive cancer, there's a chance it can come back. So there's no guarantees that this will prevent it, but it gives you the best chance. There are 3 types of systemic treatments. The first one's chemotherapy, and I'm going to talk to you in depth about the chemo regimen we're going to recommend. The other 2 things I'm just going to mention briefly. One are biologic agents. Biologic agents are things like Herceptin. Have you heard of that before?
Can you repeat that, please?
Have you heard of Herceptin?
No.
Herceptin targets the HER2 receptor, which is overexpressed in certain breast cancers. Your tumor did not overexpress it. Your tumor is HER2 negative. So you do not need these agents that are targeted at HER2. So no need, I'm going to write this here, because tumor does not overexpress HER2. The reason I'm mentioning this is because as you're sitting in the waiting room, you're going to talk to people. And they're going to say, oh, I'm getting Herceptin. And then you're going to say, why didn't Dr. Goldberg mention that to me? This happens all the time, so I mention it here, but tell you you don't need it because your tumor doesn't express the target
That's what we were
that binds.
talking about before. We started to draw little receptors just because she said, what does triple negative mean? And so I said, no estrogen, no progesterone,
no HER2. So if you have the HER2 receptor, the Herceptin binds to it. Yours, you don't have this receptor, so you don't get the medicine that binds to it. And your tumor here didn't have any of these receptors. But in your initial biopsy, there was a few of these estrogen receptors, but only 10% of cells had them.
Okay.
So we'll still treat it. That's the next thing, the endocrine therapy. Endocrine therapy means treats the estrogen receptor. So you will get it, and that comes after the chemotherapy. It's not done at the same time, it's done afterwards. And you won't have as much benefit from it as someone who has 100% estrogen tumors, but you still will derive some benefit from it. And endocrine therapy is, in premenopausal women, is tamoxifen, 20 milligrams by mouth daily. When was your last period?
Well, I don't think I received. It was, it was supposed to be in, the last one was in October. I don't remember seeing the one for November.
Okay, so October. Are your periods irregular or regular?
No, irregular.
Okay. So sometime in October. And have you ever had a colon, when was your last colonoscopy?
Probably February.
February of this past year? Okay, so up to date with colonoscopy, up to there. And when was your, did you ever have a bone density scan?
No.
No. And when was your last GYN exam?
July.
And you had a pap smear then?
Yes.
Good. Okay. So the chemotherapy we recommend, which is the most aggressive, best chemotherapy for young women with tumors that are stage 2 or greater, is ACT chemotherapy. It's 2 drugs, AC. A stands for adriamycin, and C stands for cyclophosphamide. And they're given in an IV in your arm 1 time every 2 weeks. So do it once every other week for 4 doses. So 4 doses over 8 weeks, followed by T, which is Taxol. And the Taxol is given in an IV in your arm also once every 2 weeks times 4. So it's a total of 8 doses of chemo over 16 weeks. So once every other week times 8 doses. The first 4 doses are the 2 drugs AC. The second 4 doses are Taxol. The AC infusions are about an hour and a half. The Taxol infusions are about 3 hours. 24 hours after each infusion.
When you say 3 hours, I sit there for 3 hours?
24 hours after each infusion, you come back for an injection or you can get it at home. It's called Neulasta. You get a Neulasta.
How do I get it at home?
Injection. We can run it through your insurance, and if it'll cover it, we can teach you how to give yourself the injection. Or do you live with anyone at home?
Yeah.
We can teach them how to give it to you.
Okay.
But not everyone's insurance covers it, but we check.
Okay.
For 20 hours after infusion, you get a Neulasta injection, and the goal of that is to increase your blood counts and decrease risk of infection. So I'm sure you want to know the next question you're going to have are what are the side effects? So everyone gets some side effects. Nobody gets all these side effects, but I'm going to go through a bunch of common ones. Most people feel more tired. So are you currently working?
Yes.
Do you want to continue to work through treatment?
Well, I work for myself, so it's,
So you have flexibility.
flexible.
What do you do?
I'm teaching music.
Oh, music teacher. Do you have certain days that are busier than others? Like, are the weekends more busy, during the week?
Well, actually, with this going on, this experience, I kind of like just kept it at a minimum.
Okay. So, you know, this is the first time since you've had your kids in like 15 years that you have to put yourself first. And if you're tired, take naps. If you know, have your kids, they're old enough, you said 11, 13, and 15. They're old enough to help you out. They can help clean the house if you're too tired to do so. And if you're tired, take a nap. If you don't feel like cooking dinner, have someone else do it. With the AC, the first 4 doses, you can get some nausea, but rarely do we have anyone who gets vomiting because we have really good nausea meds. You can get other GI problems. You can sometimes get diarrhea with this. You can sometimes get constipation, obviously not at the same time, but you can sometimes get constipation followed by diarrhea. And sometimes people get mouth sores, and sometimes people have no GI issues. Many people who get chemo experience a change in taste or a metallic taste. So things that you usually like to eat may not taste as good, especially water. We encourage you to drink 2 liters of fluid daily around the days of chemo to flush it through your system, and it often tastes metallic-y. So squeezing orange in it or lemon in it or mixing it with Crystal Light or other things to kind of get the flavor better. Taking vitamin water or coconut water helps. You have to drink lots of things. Everyone has a different threshold for what they like. So get after the first chemo a bunch of things at home and see what you can go down. You can get nail and skin changes. So your nails may turn black during chemo, but it's temporary. And you may get hyperpigmentation of your skin or your tongue. But again, it's temporary. Okay? So after treatment, these are all annoying things, but after treatment, they all get better. You're going to get, from the Taxol, you get what we call neuropathy, and that's numbness and tingling in your fingers and toes. But it's, again, temporary. It gets better over time. In most people, it goes away totally with just the 4 doses. In some people, you have a little bit of residual. You're going to get total hair loss, what we call alopecia. Did you hear that? So that's upsetting to many people. So there are things you can do. Sometimes the Penguin cold caps are an option, where you can rent cold caps to try to prevent hair loss. But if not, about a week after your treatment, about 14 to 16 days, you're going to lose all your hair. It usually falls out in clumps and pretty quickly. So sort of 2 weeks after starting. But we can give you prescriptions for wigs, or you can wear hats or scarves during it. The chemo may put you into premature menopause or make you infertile. Are you done having your kids? Okay. That's good. You can get, like most people, lose their periods during chemo. And given your age and the proximity you are to menopause, you likely won't get them back. So it'll likely be permanent loss of periods. So it likely will put you into menopause. Okay? These are all annoying side effects, but not dangerous. There's a few more serious side effects. One is what we call myelosuppression. That means a decrease in your blood counts. Okay? So in particular, the chemo will decrease your white blood cell count, which are your infection-fighting cells. So, if you get a decrease in your white blood cell count, it increases your risk of infection. So I want you to get a good thermometer at home, and if you're not feeling well, take your temperature. And if your temperature is greater than 100.4, you need an evaluation. Which means coming in, you live in Brooklyn? So are you by any hospitals there?
Yeah.
So you can either go to a local ER or you can come here to our urgent care, which is just for outpatients. And if your temperature is greater than 100.4, they'll check your blood counts. If your blood counts are low, you'll be admitted to the hospital for IV antibiotics. And that until your counts come up. And that happens for about 4% of all women who receive this. If your counts are fine, you'll be checked for an urinary infection, and pneumonia, and then be discharged home. Okay? There's 3 more serious side effects, and that is with Taxol you can get allergic reactions that can be serious in nature. To decrease the risk of that, we give you steroids the night before and the morning of chemo. And that helps to prevent allergic reactions. With the adriamycin, you can get weakening of the heart muscle. And what that can do is, in worst case scenario, be irreversible. Sometimes it's reversible. And it can be something like a congestive heart failure, which would require you to take blood pressure medicines for the rest of your life if this happens. There's about a 1% chance in all comers that you get weakening of the heart muscle. Sometimes it's reversible, sometimes it's not. We do baseline echoes to make sure your heart's normal before we start. And then we monitor you. So if you start having symptoms, we would repeat it. If you see a decline in your heart function, we give you meds to help strengthen your heart. And depending on the situation and the reversibility, you may need to be on a blood pressure medicine for the rest of your life. And the most serious but rarest side effect is that any time you get this type of chemo, you can get a secondary blood disorder or a myelodysplastic syndrome or a leukemia. But that's less than half of 1%. So these are the side effects. We're going to give you forms, we can give you patient information to take home that talk about these drugs and talk about the Neulasta. And then we would have you come back. When you come back for an appointment to start, it's a long appointment. We generally like to start chemo 4 to 8 weeks after you've had your surgery in that sort of window, and they can schedule that outside for you. And we would start you, and then it's 16 weeks of treatment.
16 weeks is how many months?
A little under 4.
A little under 4.
Mm-hmm.
So we would begin like in 2 weeks, or?
Sure.
No, I'm just saying, you said after surgery. How many weeks after surgery?
Generally 4.
4 weeks after surgery.
And it's been about 2, so in about 2 weeks.
Okay.
So we give you the information on this. You can review it at home because I know it's a lot. The appointment next time when you come back is also long because we'll make a whole calendar for you. My nurse will spend a lot of time talking to you about the nausea meds and which meds to take which day, and a whole calendar, and review these side effects since I know it's a lot of information for one day. And we'll review everything again with you next time.
Okay.
And then we would get started, and then after next appointment, the appointments will be normal. They won't be so long. But every time you come for chemo, you have to give yourself a half a day. There's a lot of waits. Sometimes there's waits to see me. Sometimes there's waits for chemo. Everything takes time. It's really for safety because I put chemo orders in, and then there's double checks by 2 chemo nurses, 2 chemo pharmacists. Then you get brought back to the chemo unit, and they double and triple check you and the bags and everything. So it just takes a long time. So we, basically just give yourself a few hours when you're coming here. And then the infusions themselves take an hour and a half for the AC and 3 hours for the Taxol.
Okay.
So just to be patient. So why don't we have you come out? I'm going to give you a copy of my note, which you can review tomorrow after you've thought about everything, and also the information cards. And then out front, they can schedule you for your appointment to start, and we'll schedule you for some baseline blood work and the baseline echo that we talked about.
Okay.
Okay?
Okay.
Do you have other questions for us?
No, you wouldn't like them.
I wouldn't like them?
No, you wouldn't. I'm going to leave it at that. But let's get started.